The CDC and the American Cancer Society recommend colon cancer screenings for anyone over the age of 50. How are you getting that message out to veterans?
So that is the recommendation, age over 50, unless you have relatives, 2 or more relatives with a history of colon cancer, or 1 first-degree relative with a history of colon cancer. So our system is really somewhat automated in that when we have a veteran here that's 50 or older, when they are seen by a primary care physician, they get what we call pop-ups on the screen. They're clinical reminders that say this patient needs to have a colonoscopy or needs to be screened for colon cancer, because not all the patients opt for colonoscopy. Some of the patients, we have a fecal immunochemical assay that we do, fecal immunochemical test called a FIT test. And that test is non-invasive, is done pretty much on an annual basis. It's a take-home test. You get a fecal sample, you mail it back in, and it's ultra sensitive in terms of detecting blood elements in your stool. And again, for those patients that want colonoscopy, then we schedule colonoscopy based on that pop-up on the clinical reminder screen. I would like to kind of just talk for a moment about this particular case, because we saw Mr. Cornell in June of 2016, and when we saw him, he came in basically complaining of a splinter, and at that point in time he was 56 years old. And I haven't really gotten an answer on whether a patient who's not enrolled in our system, whether that clinical reminder will pop up for that primary care provider when a patient who is not enrolled in our system. Because I don't know if I'm sure you know this by review of his record, but he was a traveler. He came here from Michigan, and when he was admitted to Penrose, basically he was a traveling vet. So he had not been enrolled in our system. So I'm still kind of doing a little research on trying to find out if indeed they would have gotten that reminder. And if not, then we need to do something to ensure that that is the case for folks that are seen over 50, that at least the primary care physician gets that clinical reminder even if the patient's not enrolled here.
Veterans are not experts in healthcare.
No.
We know that.
Right.
You guys are. If I'm over 50 and I go see my primary care physician, I trust that they will recommend a colon cancer screening for me. How confident are you that all veterans over the age of 50 that are enrolled in the VA system are being told and advised to get these types of screenings?
I'm very confident that the vast majority, and this, again, this is a rare exception, and I'm not certain that they didn't get the clinical reminder. And because this was the visit in June was such an abbreviated visit for a splinter, there may have been a conversation between the primary care physician and the patient that the primary care physician didn't go into great detail in the note that they wrote. And that could have been for any number of reasons. Sometimes it's because the patient says, "Doc, I got a splinter in my finger and I want to get it out of here, and I want to get out of here," right? But I'm very confident that our system, our automated system, alerts the primary care physicians when the colonoscopies are screening. And that's not just for colon cancer. We have the same type of issue for measuring hemoglobin A1Cs in diabetics, for mammographies in our female veterans. So the system works pretty well.
Turning to chemo treatment, I understand chemo treatment through the VA isn't available in Springs or Pueblo, so talk to me a little bit about if somebody does need chemotherapy, what alternative do they have to get the treatment they need?
Okay, if we exclude choice, then there's capability for the VA van, and we can provide transportation back and forth from those locations. The nurse navigators that work in hematology oncology are very good about scheduling the patients around their schedule on what they can accommodate, along with the schedule for the DAV van. Some of the veterans are also, in terms of travel, they can have a friend bring them to their appointment. they can have a family member, and in some cases they'll be even reimbursed for the mileage. So there are alternative ways of getting to the Denver VA. Now, that being said, there's not a requirement per se. The one reason I think that the hematology oncology folks here want to see the patients is because they want to ensure that they're getting the best care possible, even if they have to go into the community to get that care. So they like to do a preliminary evaluation on them. But there are patients that outside of choice that we approve for non-VA care, and that's also, you know, potential for veterans that can't make the trip from Pueblo or from Colorado Springs.
So if a veteran does not want to take a van or a bus from Pueblo or Colorado Springs up to Denver, what other options are there on the table?
Just primarily, again, non-VA care if it appears that they need to have non-VA care. And there are various reasons why, right, that a person wouldn't be able to travel. Some of these vets that have, specifically they have cancer, they're not the healthiest people in the world. So we would, you know, be more likely or more inclined to approve non-VA care for those folks. Now, generally speaking, when a non-VA care consult is placed, we review that consult for its merits. So does this patient, is this convenience, or is this a medical necessity? And I think the same thing, and I don't know when you want to, you know, or if you want to discuss the choice program, but the same thing is true of choice. Under the choice program, there were pretty stringent rules set up in terms of if a patient lived greater than 40 nautical miles or 40 miles away from a facility or were on a wait list for greater than 30 days. But there was an exclusion for choice called the unusual or excessive burden. I don't know if you've read about it or seen it, but it's UEXB. And for those patients that we needed to have treatment in their locale, we can write justification, medical justification for getting that treatment through the Choice UEXB program. And geo burden is one of the, you know, it's also one of the options for choice.
The VA just moved into a brand new facility down in Colorado Springs.
Right.
So some veterans may look at this and say, you're in a bigger building, why can't you bring this technology and experts down here to perform chemotherapy treatments? We're not talking about one or two veterans with cancer in southern Colorado. We're talking about
Several.
dozens.
Right. And it is, I mean, we did move into a clinic that we've outgrown. I mean, we don't have the staff, obviously. We don't have the pharmacy staff to do it. We don't have the facilities there set up to be able to do that. Chemotherapy is pretty complex. And particularly at Colorado Springs, we are really space limited there right now. But if we were to have the space, when you start talking about offering chemotherapy, it's not just bringing in the medication and giving it to the patient. A lot of these medications are mixed on site, which requires an extensive lab environment with hoods, protective equipment, OSHA standards you have to meet, because when you think about it, a lot of these medications are toxic. And so exposure, unintended exposure, is not something that we want to deal with. So it's, and you know, aside from just getting the medications, then it becomes a, where do you do the infusions? How do you know, what kind of monitoring is required, that sort of thing. So it's not simply that you just walk in and set up a clinic for chemotherapy. It's a very complex process. We pretty much look on a daily basis on how we can better utilize the space we have there. But you know, the primary emphasis for us right now is access in primary care and mental health. So as we add staff, and we have countless vacancies right now in both of those. So as we add staff, that's primarily where we're adding our staff.
Do you know, are there any types of plans, interactions, discussions taking place behind the scenes to bring cancer treatment and chemotherapy further south?
Not to my knowledge. And I've questioned our chief of hematology oncology, and she basically said that, to her knowledge, those conversations have not occurred.
Do they need to occur?
Perhaps. And again, I look at this as, I mean, we all realize that the cancer patients are very sick. And, you know, driving back and forth between Denver and Colorado Springs with Pueblo is certainly not optimum. So should they occur? Yes. In the absence of space, you know, would they occur? Should we, you know, look at other places in Colorado Springs if we, you know, would expand further? I would say yes.